Top Bed Talk.
Majerison here. Today's piece is an EBPOM highlight. All this week we're focusing on EBPOM as we get ready for EBPOM Live from London, the groundbreaking perioperative medicine conference that you can attend without having to leave your bedroom. Ensure you attend EBPOM Live from London. Go now to ebpom.org and find out more.
It's my great pleasure to introduce the next speaker, both friend and colleague, Chelsia Gillis. She's a PhD candidate at University of Calgary. She's a registered dietitian and a Canadian Vanier Scholar. She did her PhD candidacy in the University of Calgary under Franco Carli, who I call the godfather of prehab. And her research interests are in nutrition, and she's also got involved in prehab and enhanced recovery, and she's leading the first prehab program for colorectal surgery in Alberta. Thank you, Chelsia.
So I'm very excited to be here. I have only had 8 hours of sleep collectively since I got here, but despite those limitations, I'm so excited to give this talk. So this is a general slide that I put up every single time I do a talk about nutrition and surgery or about prehab and surgery. And it's important to really understand what are we trying to achieve with nutrition prehab. And really, any decent nutrition prehab program should minimally include two components. The primary one is to avoid malnutrition, and not just avoid malnutrition, but to optimize overall nutrition status. And the secondary objective is to support anabolism. So nutrition and exercise can work together to give you the biggest bang for your buck, to increase and support muscle protein gains, as well as prevent muscle protein losses. And I just want to point out here that after hearing some discussion yesterday, I realized that there's probably a few people who are only focusing on the secondary objective and not the primary objective. And if you don't focus on the primary objective, you will not be able to get the anabolic gains you expect from your secondary objective. So I really want to make that clear. And because I have to make that clear, I had to add about 5 or 6 more slides, so I hope I will finish this on time. If I have time, I will talk about what you can do, why it's important, and the how, which is the patient. Nutrition's a behavioral intervention. We just heard all about behavioral science, and even if we figure out that patients need, like 30.2 niacin equivalent units, it doesn't really matter if we can't get patients to eat it. So the how for patients is really important. So first, what are you going to do? If you want to implement a nutrition prehab program, it's probably going to look a lot like this. First, you need to have a system in place to screen patients for nutrition risk. And these tools can be done by nurses, they can be done by patients themselves, and then when patients are screened, they're deemed to be at nutrition risk, they're referred on to a dietitian who does an assessment. And I want to take a few minutes to explain what a nutrition assessment is all about. So when you see people present these slides about that they did a 1-hour nutrition assessment and counseling, it's quite comprehensive. What it involves is looking at a patient's anthropometry, looking at their weight, their body composition, looking at their biochemical data, their blood work, medical tests, their clinical data, their medicines, taking a diet history, which might mean they did a food record for you, or you have to record their 24-hour dietary intake. Now we look at their functional measures, and all the while, as you're taking in this information, you have to think about what are the patient's needs, what do they want, and what are their preferences, because the patient is the one who has to implement these things at the end of the day. And then you develop a nutrition diagnosis based on this assessment. And I have some examples. The first one is actually just kind of a joke. Excessive protein intake is the problem, and it's related to misinformation. So I just wanted to, that's not usually what happens. Usually in your nutrition diagnosis, the things that you come up with would be, either poor protein intake or malnutrition, and it's related to a swallowing difficulty, or it's related to poor intake or poor appetite. Nutrition impacts symptoms. And I really want to stress this part, because if you just implement a standardized intervention and you do not have a dietitian who's there to assess the patients, who's there to understand the root cause of the nutrition problem, you won't be able to fix it. Because if you have a patient who has a swallowing difficulty, and that's the reason why they're malnourished, and you're saying, these are a list of high protein foods, please eat them, that's not going to help if the problem is you can't swallow those foods like a big hunk of steak. So it's really, really important to meet that primary objective, to avoid malnutrition and support overall optimization of nutrition status. And that is really the primary objective. And the way dietitians treat patients is not a one-size-fits-all approach, and that's because of the assessment and the diagnosis. So I wish I could just give you the recipe and say, for every colorectal patient, this is what you're going to look for every esophagectomy, this is what you're going to look for, but it's disease-specific and it's patient-specific, and it really requires the dietary support. The protein supplement is just a small part of this. It's an important part, but it's just a small part. And where this comes from is from the exercise literature. It's well researched in the exercise literature that if you want to support anabolic gains, protein's important. Protein, the amino acids, are substrates to building tissue. If you don't have the substrate, you can't build tissue. Why do we come up with this 20 to 35 grams? Several studies have found this. This has been repeated several times. And on the y-axis, you have your muscle protein synthesis. And on the x-axis, you have doses of protein intake. Every time you increase the dose of protein intake from 0 to 10, from 10 to 20, you build more muscle. Muscle protein synthesis increases. But if you go beyond 20 grams, from 20 to 40, there's a plateau. There's no further benefit of stuffing more protein down anybody's throat. So this is not about whole body protein needs. I'm just talking about muscle protein needs at this point. In our prehab programs, we do have a component to support anabolic gains using whey protein supplements, typically. Why do we use whey protein supplements? It's a research program for us, so we're standardizing our intervention. But in your patient care, you can ask patients to drink milk. If you have patients who are also malnourished, you should get them to take oral nutrition supplements. They need the extra calories. They need the extra micronutrients. In our population, 2/3 of our colorectal patients are obese or overweight. They don't usually need extra calories. So we focus on providing the protein part of this component. But you need the dietitian. You can't get away with having a great nutrition prehab program without a dietitian. And when we look at that, I love that pyramid. So if you think about the patient who would be the universal patient, the patient who you can just give general nutrition advice to, the dietitian at your hospital may be able to come up with a handout or a class that's based on specific disease requirements. And also that dietitian will have experience knowing where patients are failing a lot, so they can boost up some of those things. And at this low level, food first approach is what we like to use. So this means you don't need lots of supplements. They're not malnourished. It's the universal recommendations we're giving. And we just want to encourage some healthy eating habits. So things like half of your plate should have vegetables on it. A quarter of your plate should have protein. A quarter of your plate should have grains. Have a fruit. Have milk with it. And that just supports overall healthy eating. And I want to point out that high protein foods don't just have protein in them. If you look at salmon has protein, but it also has omega-3. It has magnesium. If you look at milk, it has calcium, vitamin D, magnesium, potassium. So meeting your carbohydrate needs, meeting your protein needs will help meet micronutrient needs. For the patient who is malnourished, though, we need a much more aggressive approach. And Lauren presented this information yesterday. And if you weren't here, I'll just kind of briefly explain it to you. we just recently analyzed this data. If you have a patient who's malnourished, so for every drop in their nutrition score, so from well-nourished to moderately malnourished to malnourished, severely malnourished, the change in 6-minute walk test before surgery drops despite providing prehab. So this means that our malnourished patients are not responding to our prehab intervention. Why? Probably because they were malnourished and we were trying to adapt their intake with food, and we needed a really more aggressive approach, maybe even as aggressive as nutrition support for some of our patients. And we also needed to monitor and evaluate them a little bit closer. So one thing that we've learned very recently is that malnourished patients need a much more aggressive approach. You will not be able to do this without a dietitian to provide individualized nutrition care plans for these patients. So that's the what. I hope that clarifies things a little bit. We really want to make sure we optimize overall nutritional status and that supporting anabolic gains is a secondary objective. Now, why is this so important? Why do you need those components? One, patients need to be ready for the surgical stress response. You've heard this a few times. We need to make sure that there's a buffer so that they can withstand the surgical stress response. Two, our patients actually don't eat very well. I'm going to show you some data to show you that everybody can benefit from some nutrition optimization. And three, you should want to do it because it actually works. And I have some data to show you as well. So first, we've mentioned the surgical stress response a few times, and I want to focus in on a nutritionally important aspect of it. And it's important to stress that the surgical stress response produces a typical, predictable response to surgery. When patients are cut, they're going to mobilize their energy reserves. Why? It's believed to be an innate survival mechanism so that they can maintain energy processes, repair tissues, and synthesize proteins for the immune response. What does this look like? Oh, let me find the pointer here. Can you see that? Yeah. The surgical trauma stimulates the release of counter-regulatory hormones and cytokines. And this causes two important metabolic changes I'd like to discuss. One is whole body protein catabolism. What this means is that amino acids from lean tissue like muscle are released into circulation and they're preferentially taken up by the liver. This is a shift in protein metabolism. Why are they preferentially taken up by the liver? The liver needs to synthesize glucose via gluconeogenesis. We need to maintain energy processes. The liver needs to synthesize proteins, like in your immune response, acute phase proteins. To give you an example, to synthesize 1 gram of fibrinogen, which is an acute phase reactant, if patients did not eat, they would have to synthesize nearly 3 grams of their muscle, or catabolize 3 grams of their muscle to support 1 gram of fibrinogen synthesis. The other metabolic consequence is hyperglycemia, and this is a result of insulin resistance coupled with refractory hepatic glucose production, and it exaggerates catabolism. So surgery is a catabolic event, and it's predictable, and we want to prepare patients for this. So if you have these two patients show up at your clinic, you have Mr. America on one side, and you're probably thinking, he can stand to lose a little bit of lean tissue. I mean, it would be a shame because he's so good looking, but he could stand it. And he would probably be right back at the gym to build up that lean tissue immediately. If you have this elderly patient here, there's no room for mobilizing energy reserves. This patient will deteriorate already compromised reserves. This is the kind of patient that we want to build up. We want to buffer against the surgical stress response. Dr. Carley presented on the first day, catabolic events for patients, especially elderly patients, accumulate. So we have an opportunity here where we can buffer against this catabolic event so that, am I running out of time? Oh, sorry. I'm almost done. So that we can maybe even prevent the incidence of frailty down the road, and so that patients are not susceptible, that they're more resilient to future illnesses down the road. And what I hear oftentimes is that oh, okay, it's pretty obvious that patient needs prehab, but my patients don't look like that. Do your patients look like this? Are they obese? Are they overweight? Some of them will be underweight. And what this CT series shows you is that despite the BMI, all 3 of these patients have the exact same amount of muscle. And the overweight patient, or obese patient, actually, if you see that ratty looking muscle, that's the fatty infiltration. And that patient, that's associated with worse clinical outcomes. Even worse, that patient is probably way worse off than the skinny mini patient. So my point here is that you can't look at a patient and know they're malnourished or they have low lean reserve. It's not something you can eyeball. So, can I have one more? Okay. So, the other point I wanted to really make why you should care about nutrition prehab is that it works. This is a study that we pooled together our prehab data. And this is a mixed effects model. So let me just orient you to this. We have 2 groups. We have our trimodal prehab group that received 4 weeks of prehab, plus they continue it 8 weeks after surgery, versus our rehab group in colorectal surgery. First, I want you to take a look at time. So we had repeated measures of lean mass. I mentioned surgery is catabolic. These patients lost lean mass after surgery. It's predictable. With prehab, we were able to attenuate this loss. Our prehab patients maintained their lean mass. With the prehab program that I just explained, the what? Maintaining nutrition status, providing those protein supplements to optimize nutrition, optimize muscle protein synthesis. And I want to stress that this is compared to rehab. Rehab is not standard care. Rehab is another intervention. So the effect against standard of care, prehab would probably be even that much more effective at maintaining lean mass after surgery. And that's all I have time for. So there's a lot more about why this is important. And if you'd like to talk about it later, I'd be really happy to talk to you about it. Thank you.
Top Med Talk.
Hi, it's Desiree Chappell here. Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Most of our podcasts from Top Med Talk are either presentations from the EBPOM conference or they're interviews with people who attend the EBPOM conferences. Have you always wanted to attend an EBPOM conference, but you were unsure because of travel, accommodation, costs, whatever it may be? This year, are you planning to respect social distancing and avoid attending large social gatherings while minimizing travel? Do you want to attend one of the most important medical conferences of the year without having to leave your home? Go now to ebpom.org and discover EBPOM Live from London. Get all the latest and greatest information streamed live to your home, office, or bedroom as you attend the conference virtually. Submit your questions, network, and hear these talks before anyone else in the world. In light of the recent COVID-19 pandemic, attendance for this conference is at an all-time high. We only have some limited spaces available. Carbon-friendly conferencing is here. Be part of the most exciting development in medicine since the invention of the stethoscope. ebpom.org.